So good morning everyone. I have a fairly dry topic here on biomechanics and its role in LVC, but I'll try to make it as practical as possible. So why do we really need to look at biomechanics? Because we understand that we need better screening criteria. There's definitely a greater emphasis on biomechanics. We have procedures like SMILE, which is supposed to induce a lesser weakening in the cornea. We also have combination procedures with cross-linking coming about, where really a good understanding of biomechanics will help us identify which are the ideal patients for these combination procedures. Now you have the Placido disc instruments, then followed by the Scheimpflug devices, which have really increased the sensitivity of us detecting any cases of form thrust keratoconus. But what we must really understand is that even with the most sensitive index like the Galilei, the Cranman-Arce index, though we are able to differentiate KC from normal 100% of the time, we still are only at around 90% when it comes to differentiating normal versus form thrust keratoconus. And it is really these form thrust keratoconus cases that we are more concerned about when we are screening them for any refractive procedure. So then came the role of corneal biomechanics, where CORVIS and the newer improvised versions of CORVIS have come, where basically it's the dynamic response of the cornea to an air puff. When the air puff happens, the cornea indents, and the weaker cornea would indent more, and based on this various parameters, based on the deflection amplitude and the radius, various parameters have been brought about. I will not go into the details, but about the amount of deformation, what is the inverse convex radius, and the ratios of these have been developed. But even this had a much lower sensitivity in actually differentiating FFKC from normals. It was able to identify KC from normals, but definitely not FFKC from normals. So then came the newer indices which are available, one of which is the CORVIS biomechanical index, which takes into multiple important parameters like deformation amplitude, integrated radius, and the stiffness parameters, which helps us in really detecting these cases of FFKC. I'll show a couple of quick examples where this is a patient with a absolutely normal scan. Bad D is absolutely white, but you can see the CBI, it is very much in red. That is, the CORVIS biomechanical index is in red. If you see the fellow eye, the patient had frank keratoconus. So the way we define FFKC is the seemingly normal eye of an other eye which has KC. And this, which could not be picked up by pentacam, was easily picked up by the CORVIS. And these are again a series of other cases which have shown that this could be cases where the other eye had KC, and these are 12 eyes which were recently published by Vinciguerra's group, where they showed normal tomography, absolutely normal tomography, but abnormal biomechanics. So it's really probably a step in the right direction when it concerns moving towards with CORVIS. But then, can we combine these two? Because CORVIS was missing out some cases, tomography was missing out some cases. So can we combine the CORVIS and the tomography and come about with an even better index, with an even better ultimate ectasia detection? So basically we are combining Scheimpflug with the biomechanics, with the statistical data which we have with the artificial intelligence, and that brings about the TBI. So this is an example of a tomographic biomechanical index where it was useful, where you can see the patient has KC in one eye, the other eye is normal. The bad D was also completely normal, but then the tomographic biomechanical index clearly showed that it was abnormal. So when you actually look at the statistical data of these patients, that this is the value of CBI to detect FFKC from normal patients, that of bad D, but then look at TBI. It has been shown in a study that a cutoff of 0.79 is probably 100% sensitive in terms of detecting FFKC from normals. I'll just take you through this quick study where it is exceedingly difficult to get that last data. You can get any number of normals, any number of KCs. But to get 94 eyes of asymmetric ectasia, that is one eye is ectasia, other eye is normal by all clinical parameters, by all tomographic parameters. When you looked at those 94 eyes, this is what they found. The bad D could not differentiate normals from this fellow eye of KC patients. Neither could the CBI. The CBI had a very wide spread, was better than bad D, but had a wide spread. But look at the TBI. So tightly knit, all the data which is available. The way it was able to differentiate KC from normals, that is ectasia in one eye from normals, but the seemingly normal eye of a patient who has ectasia from normals was nearly as good as the efficiency in which it was able to differentiate KC and normals. So really, it's probably the step in the right direction, and in the future, this could come into vogue altogether. But I will still leave you with a caveat, where this is a patient in our own clinic, and I have a few cases of this. Completely normal cornea, completely normal tomography, CBI, TBI, absolutely normal. TBI is 0.07. If this patient came, I would do LASIK 100% of the time. But this was the other eye of ectasia. So we are probably stepping in the right direction, but we still have a way to go before we are sure we can proclaim that this machine is 100% sensitive and specific. So that's where probably in the future, BRILLOUIN microscopy, where we've had the opportunity to work with the earlier prototypes, is probably going to come into vogue, as this can actually detect the intrinsic viscoelastic property of the cornea itself. Now, till date, we all know theoretically that the anterior cornea is stronger, the posterior cornea progressively becomes weaker. But we had no device which could actually measure this. The BRILLOUIN microscopy is the first device which has been able to measure that the anterior stroma is stronger and progressively becomes weaker as we go into the posterior regions. It is also the first instrument which has been able to demonstrate that a cross-linked cornea, at least the anterior portion of a cross-linked cornea, is stronger than compared to the untreated control. And as it goes posteriorly, where you would imagine that the cross-linking effect is not there, it is similar to that of an untreated eye. So we have a plethora of new investigations available, and probably an early diagnosis and timely intervention in these cases might really improve our screening criteria as we go ahead. Thank you so much.
Thanks a lot, Shreyash. There was a lot which each of us learned from your